see my screen?
Yeah.
Okay, anyway, so TB. So let's start with who gets TB.
Anybody could get TB, but usually don't it be like a lot of homeless people usually get it, more prone
Okay,
to it.
all right, so we'll look at the, okay, very good. Let's look at the um, types of TB and then we'll look at the risk factors. So TB can be latent. Latent TB infection is you're exposed to the disorder, but you're not sick. Meaning by sick, I mean you're not symptomatic. So therefore, if you know not symptomatic, you're not contagious, but you do have it inside you. Primary TB infection, this is the active TB, meaning you have it. Primary progressive, you have it, but then it's either your and it's not what we say um you have the infection and then you're still continuing to have the infection, meaning you're still under treatment, or maybe you're not treated yet. And then finally, drug resistant strain. This is the most difficult to treat. This is the one that usually affects immunosuppressed individuals, or those with other chronic conditions. So let's start with latent TB. I'll use myself as an example. So, upon migrating here around 2004, I didn't have TB. Okay, so I came from a country that has endemic TB. Never got it there. Contrary to as our healthcare professionals back home, because we're going to be positive anyway, that's not true. We still have PPD quantiferon testing. Because just because it's endemic doesn't mean everybody has it. Okay, so we still have to protect our patients from our healthcare workers. So we still have the same precautions. However, when I came here, 2 years after, exactly 2 years after, during a routine physical, so I now tested positive. My PPD was positive. So that means I was exposed here. And, of course, my thought was, I don't believe this. No, I grew up in a country with lots of TB, never got exposed. Now come here, I get exposed. Anyway, long story short, so I have latent TB. I have no symptoms, and exactly here, I have no symptoms. I wasn't sick. I wasn't contagious. But because I still have the bacilli in me, which could be activated, so here, so if a time comes that my immune system will be weakened or compromised, it will become reactivated, and then I will now have progressive TB. So that means the primary TB infection has the potential to become either latent or progressive TB. Does that make sense? I don't know when my primary TB infection was. Just that somewhere between my first PPD testing and then the time when my PPD tested positive, between that period, I know that was my primary TB infection. Okay. But I did not become progressive. The one preventing that is my immune system. So apparently I have good immune system because I didn't have primary progressive TB infection. So what I do have is the latent TB. So I know someday if my immune system becomes compromised for whatever reason, I could reactivate it. So I opted for treatment. So I went through the whole treatment, 6 months of INH and rifampin, and then that's over with. So I'm treated, no more. So that's the primary. Then we have the primary progressive, which is now the symptomatic stage of infection, meaning you have active TB, you got sick with the TB. So definitely you need to be treated because you are very contagious. And this is also very contagious, but the thing is, these do not respond to the normal or regular TB treatment that we use for most people. Diagnostic testing. We have several. You're aware of the PPD and quantiferon because you guys also went through this, right? It's a requirement. Since PPD is still widely known, the difference between PPD and the other testing, which are quantiferon, gold, was it mentioned here? We have PPD. No, I didn't mention here. Um, so you're aware of quantiferon, right? And then we also have the T-spot, TB test. There's another DNA-based testing. PPD is prone to false positives because of the BCG. Who among you here received BCG as a child, as a baby? All right, so some of us here, right, were given it because of the country of birth, right? So we were given BCG because in a country where TB is endemic, we have to protect all newborns. So we were given the BCG vaccine. Because of that, though, getting a PPD test, especially if it's done within the 10 years of getting a BCG, can result in a false positive. However, new data shows that the BCG vaccine we received as a child did not provide lifetime immunity. I am living proof. So I received BCG at birth. Obviously, I turned positive. I was what 20 29 years old at that time. So the BCG vaccine didn't give me lifetime immunity. So it waned over time. That's why I turned positive. So as I was exposed to TB, luckily I wasn't, um, I wasn't weak enough or susceptible enough to have the progressive type. So what I had was the latent TB. The other tests, like quantiferon, for instance, would be the preferred way to test for those who receive the BCG vaccine because the quantiferon is not influenced by the BCG vaccine, meaning it won't give you any false positive on a patient who received BCG. Does that make sense so far? Questions on testing?
Can you repeat that, Professor?
Okay. In a patient who received a BCG vaccine, when we use the PPD test, the MAN2 test, it could provide a false positive, meaning it could turn the patient's test positive not because they are exposed to TB, but because they were given the BCG vaccine, which is a weakened TB bacillus. So to confirm that it is not a false positive, we have to do a quantiferon gold. The quantiferon gold test is not affected by the BCG vaccine. Meaning, if you're positive on a quantiferon gold test, then that means you have been exposed to TB. Does that make sense?
Yeah.
Okay. All right, since we're still using PPDs, especially in nursing homes or in school, none of us, I mean, not all of us receive get the BCG, we still get the PPD.
Would you say
So here is a interpretation table. This is grabbed from CDC here, adapted from CDC. So this is the same interpretation from the CDC website. Okay, so we'll put people in three different groups. A PPD, and it's based on induration, correct? Not the area of redness, but the area of where the reaction is raised, meaning if the bump is greater than 5 millimeters, then it's positive in these patients. If the induration is 10 or greater, in these patients, it's positive, or an induration of 15 or greater is positive in these patients. Okay, let's start with the 5 millimeter group. If you look at the profile, these patients are immunosuppressed. So either from HIV, having constant contact with somebody who has the progressive type or the active type, you know, if you live with them, or if you have um, a patient immunosuppressed for various reasons, either because they got a transplant, for instance, so have to take immunosuppressants to prevent rejection, taking steroids for autoimmune disorders like rheumatoid arthritis, COPD, inflammatory conditions like that, lupus. What else? Who's Addison's disease? You know, adrenal insufficiency people, um, multiple sclerosis people. Okay, so we have several people on steroids or other immunosuppressants. The second group are the following: immigrants from high prevalence countries like the Philippines, Mexico, most Asian countries, including China, Thailand, Singapore, or also in South America, and also the Caribbean. Okay, so these are high prevalence countries, okay, where TB is quite common. Also among IV drug users, residents and employees of high-risk settings. High-risk settings are nursing homes, rehab centers, mental health centers, homeless shelters, prisons, um, and similar, you know, close space, very high population facilities. Okay, those are high risk settings. People working in the laboratory who are handling sputum, blood, or other body fluids. Um, Persons with clinical conditions that place them at high risk. We're talking about diabetics, heart failure patients, dialysis patients. Okay, so these are chronic illnesses that make them susceptible to disorders. Children under 4 years of age, or infants, children, or adolescents exposed to people who are belong under this. Okay, so if these people here get a PPD induration of 10 or greater, then it's positive. And then finally, for all other people not belonging in the 5 group, not belonging in the 10 group, then they require a 15 or higher. You understand why there is the difference, right?
Yep. I
For
guess it's
example, why is a 5 considered positive in these patients? Why
because you're
so low?
maybe because you're so close to them. So as it is because of the sensitivity, you know.
Not really.
I think it's
Because
because
they're
they are
already immunosuppressed.
immunocompromised.
Okay, because the induration here, when you plant a PPD, it's actually your immune response that causes the reaction, correct? So in people belonging in the 5 millimeter group, these patients have very weak inflammatory responses. So you can't expect them to mount a 15. Okay, so a 5 in duration here is already considered positive because these patients aren't able to mount a normal inflammatory response to any vaccine or in this instance, a diagnostic test, okay, of planting um, a protein derivative of TB. Okay, so let me ask, who among you here? Let me ask Sheila. Where do you fall? Are you a 5, 10, or 15? Or Miss Omo? Miss Omo, are you 5, 10, or 15?
Well, I've never had tuberculosis before.
Well, yeah, so that's why I'm asking. If I put a PPD on you and you have a positive result, are you under the 5, 10, or 15 millimeter group? I'm
Um,
asking because of your current status. Are you in the 5, 10, or 15 group?
would I be 15?
What kind of work do you do?
Well, I'm not working now, but I was a CNA,
Okay, so you work in a
a
high
healthcare.
risk. Yeah, so you're here, right?
Okay.
Yeah, you're not a resident, but you were an employee of a
Yeah.
high risk thing. So you're a 10. Okay, so
Okay.
if you get right. So if you get a 10 millimeter induration, that's already considered positive. But if it's less than 10, that's negative. You need at least a 10. Does that make sense?
Yeah.
Okay. What about Danielle? Where are you? Are you 5, 10, or 15?
I don't know. I guess potentially I would fall under because as an employee, like even though I'm not in the hospital, I'm a massage therapist, so I'm still working on like a ton of bodies.
Uh-huh. Okay, that's correct. You are a 10. Plus, let's say you're not a massage therapist. The fact that you guys have already gone to a nursing home or a hospital during your clinicals,
Right.
you're already under 10. At least everybody's at least a 10 in this class,
That makes
right?
sense.
Yeah, you wish you were 15, but no. Every one of us are now at least under 10. Unless some of us have immunosuppression, then we would be a 5. All right. So question on the exam would be, I'll give you the patient's profile, what they look like, where do they live, what do they do, and then I'll give you a PPD result. Then you interpret whether it's positive, or I ask you what should be done next. Should they be treated? Should we get an x-ray? Whatever. All right, so let's continue. Treatment. The doctor decides the treatment, so it's not us. So we don't have to answer, how long it will be, but the minimum is 6 months for latent TB. Active TB, there's no way you can treat it in 6 months. It has to be longer than 6 months. The For latent TB, you only need 2, but for the progressive type, which is active type, is a basic 4-drug combination. This is from CDC. Okay, although there are now different combinations to facilitate compliance, because it's not which one's easier to do, taking 4 drugs or 1 pill. Better
One
to take
pill.
Yeah, it's
One
better to
pill.
take 1 pill, right? Okay, so they're now making drugs like that. So 4 drugs in 1 pill. Okay, there are options like that now, which is better in um, patient compliance, because remember, what is the profile of the patients that have TB here? IV drug users, homeless people. All right. So I mean, I'm not saying people like you and me won't get TB. We do, but a compliance, it won't be a problem with us, right? Because we have insurance, medical insurance. So we just simply get our prescription filled, we pick it up, and the doctors trust us to comply with the treatment. No problem, because we are compliant, or we are assumed to be compliant. However, people who are now, or who are homeless, who don't even have health insurance, insurance, or much less money or the means to get the medication, right? However, we do have funds. This is funded by taxpayers. This is communicable, so treatment is free. I didn't have to pay for my treatment, okay, because well, although I wasn't a danger to society, but it's covered um, by the government. It's free. Medications to treat TB you don't have to pay for that. Okay, once we confirm somebody has TB, the active part, of course, so this is the primary progressive TB because they're the ones, or the drug resistant one. So these patients are symptomatic, so therefore they are contagious. This is your airborne precaution. So what do we do? Thank you for reading, Miss Mail.
Immediate isolation of the patient with suspected or confirmed TB infection in a private room with negative airflow capabilities is a priority. Negative airflow occurs when air moves into the contaminated area or into the patient's room from bordering areas. The institution of airborne precautions, the use of an N95 mask respirator for healthcare personnel entering the patient's room, requires fit testing, and a snug fitting surgical mask for visitors are essential interventions. The patient's movement and transportation to other departments should be limited to essential needs only. Patients who must leave the negative pressure room should also wear a surgical mask.
Okay, that's self-explanatory, right? So questions on the tests about what to do if the patient leaves the room, for instance, or some visitors come in, because we don't restrict visitors. They have to have visitors. There's really no law that you can't enter a negative pressure room, okay? So visitors can enter. However, when they do, because we don't fit test them, only healthcare personnel are fit tested with the correct N95 mask, and visitors are not. So all they can do is wear a snug fitting surgical mask for both the patient and the visitor. Okay. And it's the same if the patient has to leave, meaning there's a procedure we have to do. We can't do it in the room. They have to go to the procedure center. Then they'll have to wear a mask.
But Professor,
Yes.
can't the family members like still be highly susceptible of catching it if they actually just got a surgical mask and not an N95? Because the surgical mask wouldn't really filter out all of the like airborne stuff.
No problem really in a negative pressure air room. All the air is constantly exchanged, meaning the air is constantly being sucked into the room and leaving through the roof.
Okay.
So why we have to
That's
wear
why they
masks?
call it negative pressure, meaning constantly, if you put a piece of paper or a piece of feather into the crack on the doorway, when the door is closed and you put a piece of tiny object there, you'll see it'll be sucked into the room. That's what
Oh.
a negative pressure room is. So constantly, as the patient is breathing, the air is constantly flowing in and then out through the roof. There's
Okay.
no problem because once the TB bacillus is already in the atmosphere, I mean, it's less likely for us to get it. I mean, this is millions of cubic feet of air there constantly moving outside, so there's really no danger.
Okay.
It's really if you're in the same house, okay, living with these people. So the assumption is these patients who are family members. Of course, if it's the visitor is a friend, not living with the patient, well, we're concerned about those. But family members most likely have been exposed already to the patient. So all we do really is test them. Um, Yeah, I mean, you don't necessarily have to treat them because remember, TB depends on your susceptibility, right? Your immune system. So you could be constantly exposed, but not usually get sick. Okay, because like we take the train, for instance. Okay, every day we take the subway. There's so many people with TB out there. Um, No, homeless people on the platforms, on the street, and inside the subway cars. So we're constantly exposed to these patients. So yeah, chances are we're exposed to TB every single day that we're out. But because you have a good immune system, you don't get sick. Okay, let's go now to, well, complication. Pretty much you'll have chronic lung disease because the TB bacillus causes damage to lung tissue, causing holes in it, and they will appear as spots, and these heal, become scar tissue. So pretty much your lungs aren't all functional now. So you have portions of your lung which are now replaced with scar tissue. Those are the complications. Let's go to, okay, the testable part here is the drug therapy. I already searched your book. It doesn't have um, side effects and teachings for each drug therapy. However, it is testable on the NCLEX because this is highly communicable. So people will be on TB medications. And so people with TB medications have to be monitored and educated on the drug therapy. Now, this is the only textbook so far that doesn't have it. So I'll have to refer you to your drug book. I will test all 4 drugs. Namely, take this, everybody, and write. So we have isoniazid or INH, rifampin, there's no other name for it. Next is ethambutol, ethambutol, ethambutol. Lastly is pyrazinamide or PZA. Pyra, Zi, NAMIDE, pyrazinamide. So all 4 drugs used for TB, active TB. All right, so use your drug book for the side effects and especially the part under nursing implications. Okay, you need to know what to teach the patient, what symptoms to report, what symptoms to expect. Like which drug, for instance, causes a yellowish, reddish orange, a reddish orange discoloration of the urine. Um, what precautions are to be taken while on the drugs, especially with alcohol, which drug causes eye damage, which drug causes liver damage, etc. Lastly is the how do we take it? We'll only test the first row, this one right here, this regimen. So these are the 4 drugs taken, and this is how we take it. There are 2 phases here. We have initial phase and the continuation phase. The first phase is 8 weeks, or that's 2 months. Look at the first row. So for INH, rifampin, pyrazinamide, ethambutol, they're taken daily for 2 months, right? So for 2 months, how many drugs are you taking? Hello?
4.
4. Okay. So for 2 months, every day for 2 months, you'll be taking 4 pills. INH, Rifam, PCA, and ethambutol. What about the next 4 months? How many drugs are you taking?
2.
only 2. So first 2 months, you're taking 4, INH, Refam, PZA, ethambutol. After the first 2 months, you're finished with the PZA and ethambutol. Now we only need to finish another 4 months of INH and rifampin. Technically, though, the CDC website says 18 weeks. So the duration really is 6.5 months, not 6 months. But this is good enough. 4 additional months. But the CDC website lists down for new infection, meaning this is a new diagnosis of active TB, not uncomplicated, not multi-drug resistant. It's 6 months to 12 months, but this is the common regimen. Put you on extensive 4-drug therapy for 6 months. 4 pills for the first 2 months, and then the continuation phase, 2 pills for another 4 months or 18 weeks. Clear? Now, this is important because, again, who are the people who get TB? Are they commonly like you and me?
No.
No,
No.
compromise.
The most
So they
susceptible, right, are the cancer patients, but most likely those homeless people, they get TB. And you know their lifestyle. Okay, they don't have it like you and me. They technically don't have a house to keep their pills in, so all their property is in that cart that they're pushing around. That's it. And their house is anywhere they can find a shade. Okay, so it's not easy for drug compliance. They need to know how long this is. You may think that compliance is impossible. Not really. We monitor these patients, the health department does. They are assigned to a case manager. So that case manager will follow these people to make sure they comply with the treatment, because otherwise they're a danger to society, correct? And we're aware of their infection, so we now have the responsibility because we know they're infectious and yet they're out there. So they have to be followed and monitored for compliance. It's not it's not anything new. In the third world, we're already doing this because in the third world, we have these patients. Okay? We have poverty everywhere there, so we have to follow them as well. So we use the same treatment protocol. We put them on direct observed therapy or DOT, DOT. So in the case of here in America, what happens is they'll be given resources, okay, to come to either the health department or a designated clinic. They'll be given fare, to get there. They'll have an allowance. They'll be given, I don't know, this is New York, so I guess they'll be given Metro cards, okay, to travel to the center, and then they have to take the pill in front of the nurse. And just like in prison, okay, or in a psych facility, they have to open their mouth. Did you swallow it? Okay, so same thing. So they do that for the whole 6 months, every single day. They probably get a meal allowance also, okay, and additional resources during the treatment period, just to ensure compliance. If they don't, they could involuntarily be committed because again they're a danger, so they'll lose certain rights. No, they'll be committed to a facility against their will, and that is, yeah, well within the police power of the health department. Any questions? Okay. How do we know that the patient is no longer contagious? All right, it's not in your book, but in case you get it on the NCLEX, I won't ask you because it's not here. Anyway, um, you need 3 negative sputum cultures. The sputum cultures can be taken 2 weeks apart. So let's say after 2 weeks of treatment, draw a sputum sample today. Okay. If it's negative, Okay, good. So another 2 weeks later, we get another sputum sample, and then another 2 weeks later. So you need a minimum of 6 weeks before you can go back to work, because your doctor won't sign a return to work note until he gets 3 negative sputum cultures. Um, when are they not contagious? Because we can't put them in a negative pressure room for 6 weeks, right? They're not contagious anymore after 2 weeks of therapy. So you give them the medications for 2 weeks and the symptoms improve, then they're not contagious. You can take them out of the negative pressure room. Um, they can um, mingle with society now, but
But Professor,
they should not stop the medication. That they should still continue.
that's what I was gonna ask. Like, if they stop the medication, would it basically like the TB come back?
Yeah, because you never finish the treatment.
Oh,
Now, the reason why there's 6 months of therapy or longer is a TB is a very slow growing organism. So any slow growing organism, it takes time for it to spread. So therefore, it takes also longer to treat it. That's why it's one of the most hard to treat, because it takes a long time. Unlike most infections, you give them a week of antibiotics, it's gone. This one is very slow growing, so treatment's really long.
so if if they start the treatment and then they stop, like, could it actually make like a super? I
Drug
don't want to call
resistant
it
strain.
super bug, but
Yeah,
yeah.
that's exactly what's gonna happen.
Uh,
So that will complicate your treatment.
yeah.
But again, that's most likely what will happen with, especially with um, homeless people, especially alcoholics. So that's a challenge there. How can you tell an alcoholic to abstain from alcohol for 6 months?
Yeah.
Yeah, because they can't drink alcohol while on these medications. They'll destroy their liver.
Would you
So,
give them something to like wean off of the alcohol or something? I don't know.
well,
No.
easier said than done, though. Yeah, that's what's supposed to happen. But again, it's not that easy to do, because you'll have to admit them in order to detox them from alcohol, because they will go into withdrawals. So admit them for alcohol detoxification, and then you can start treatment for TB.
So do you think it would take I mean, it's probably too long to get treated for TB. Can it get worse or something? I don't know.
Well, they do get worse, but again, the bacteria is also very slow growing, so the damage won't be as acute as you would think for other conditions. Okay, because it's very slow growing, so the damage will be over time. So there's really it doesn't have to be, in the case of alcoholics, it's not really that urgent. Okay, but all you do is really isolate them because they are contagious.
Okay. Okay.
All right, it's 11:37. That's all the time we have. We'll continue with COPD next week and finish with cystic fibrosis, and that should be it. For ABGs, we'll do it during Skills Lab. We'll have a review and some practice activities on ABG.
Hello?